So good evening and a warm welcome to all the dignitaries present here. I'm Sreyoshi from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event, hosted by the Cancer Kids Strength of Smiles Doctors Network-Maharashtra. And the focus of today's session is Webinar 13 Immunotherapy and Targeted Therapy in Pediatric. So let's begin today's session, for which I would like to invite Dr. Pankaj Sir to take over. He is Senior Consultant, Department of Pediatric Oncology at NCI Nagpur. Over to you, sir. Kindly proceed with the talk.
So thank you, Shreyasi, for your this kind words. I would like to start the session. And Shreyasi, you have the slides for the introduction part.
Yes, sir. I just have a flow of the session. I'm just sharing it.
Okay, so you don't have this thing?
No, I don't have the CV, sir.
Okay, that is okay.
Okay.
Share this. Share
Yes,
whatever you have.
yes.
Okay, sure.
So before
Share that slide that you were sharing just now. It is the same presentation.
Okay, I'm sharing once again, ma'am.
Yeah. So before the Shreyasi.
Just a minute.
Okay. Okay.
Is it visible?
Yeah, it is.
Okay.
So welcome you all. This is our actually a little bit of effort to discuss a little bit of academics in our meetings, and this is in that line. So today we are going to discuss about the immunotherapy and the targeted therapy in pediatric hemato-oncology, especially because we know that the lot of immunotherapy in the market for the adults, but really we need to update ourselves. What is going on around the world and what are actually, so we will start to take principles of immunotherapy and targeted therapy and what are the advances in pediatric hematology oncology, and then we will discuss. So for that all discussion we have a few speaker with us. So Dr. Badira is with us. She's a professor pediatric oncology at Tata Memorial Hospital, Mumbai. So she is going to speak on the immunotherapy and or targeted therapy in solid tumor, in especially in pediatrics. Our next speaker, can you change the slide? Shreyasi, can you change the slide? Yes. So okay, if you have this slide, that is also okay. So Mukta ma'am is going to be the panelist for with us. So we will discuss a few points regarding the pathology and the correlation with the molecular findings with Professor Mukta Ramadas. She's my teacher also. She was my teacher at Tata. She's a professor in Department of Pathology at Tata Memorial Hospital. And so we will, whatever be the question have from the audience or what we have question, we will discuss with her. Next slide, please. And Dr. Om Shri Shetty, she is their consultant, and she is a research officer in Tata Memorial Hospital. So she is going to be the one of our panelists. The next slide. And Dr. Suruchi Agrawal, she is from the MedGenome Lab, and she has done her PhD Human Genomics, and she is quite experienced in NGS, next generation sequencing. The next slide, please.
Dr. Prashant's slide is, I think, the first one. You'll have to share that.
Yes, first slide, please. Next slide.
The next one.
Yes. So today we have Dr. Prashant with us. So he's one of our speaker, and he's the HOD blood and marrow transplantation and pediatric hematology at Vijayawada Children's Hospital, Mumbai. So I welcome all my speakers and the panelists for this little bit a newer way of therapy, that is immunology and the targeted therapy. Before we start it, I would like to give you the brief about the principles of the immunotherapy and targeted therapy. I would also like to share one or two interesting cases with all of you where we used targeted therapy and got an excellent result. So can I share my slides here? So we know that in pediatric malignancy, these are the established way of a treatment. First is the chemotherapy, the surgery, the radiotherapy, and now the immunotherapy and targeted therapy, newer for us. So we'll see what are the principles of immunotherapy. So we know that our body has its own mechanism to deal with any foreign bodies or even any abnormal growth is happening in the body. So the elimination of the tumor cells through the autoimmune pathway is the key to immunotherapy. Immune response to tumor dominated by the cellular immunity and the killing of the tumor cells by natural NK cells and NK T cells. So this is how our body takes care of that. And these are the two basic mechanisms how the tumor develop in the body. First is called immunoediting. So body tries to eliminate all those abnormal cells, cancer-specific new antigens, and prevent the formation of the tumor reactive T cells and subsequent destruction of the tumor cells. There may be the equilibrium state also there. Tumor growth is held dormant by the adaptive immune system, which may provide a long-lasting, highly specific responses against the cancer cells, and the escape if the body is not able to hold or to control the growth, then there is subsequent proliferation and T cell exhaustion is there, and mechanism behind this tumor evasion. So loss of tumor antigen expression. This way, the tumor tries to escape the immune mechanism, down regulation HLA from the cancer cell surface, and recruitment of the T regulatory Tregs, myeloid-derived suppressor cells or tumor-associated M2 macrophages, which all increase the immunosuppression. These changes lead to the upregulation of the inhibitory receptors. We know that CTL4 or PD1 on the T cells or of inhibitory ligands like PDL1 on the tumor cells. So this way, how the tumor evasion is there, and immunotherapies aim to counteract this escape phase and reinvigorate the patient's immune system to recognize them. And this is the basics of that, and it's a pictorial diagram where we can see the body tries to eliminate. There may be the equilibrium between the two, fights is going on, and once the tumor advances or they overpower our immune system, then there's a frank malignancy is there. So what are the ways of immunotherapy? First is the antibody targeted of cell surface protein. So we know that MAB or monoclonal antibodies attaches to the specific tumor surface antigen and activate the NK cells and macrophages to release the cytotoxic granules to kill tumor cells in a process known as an antibody-dependent cellular toxicity, ADCC. We know this thing, and very good example is dinutuximab, that is used for neuroblastoma, but now has a role also in a osteosarcoma. There is a BiTE, that is a bispecific T cell engagers as well, where the antibody which contains two single chain variable fragment connected by a flexible linker that bring into close proximity the CD3 receptor of the T cells with the tumor antigen, resulting in T cell activation and cancer cell cytolysis. Blinatumomab. So Dr. Prashant with us, he will tell us some detail about the blinatumomab. A third approach is like that you couple the antibody with cytotoxic agent such as like vedotin. Example, brentuximab vedotin. So we know that now it is the standard of therapy. Brentuximab vedotin is one of the component of standard of therapy is the ALCL. Other way of augmenting the immunotherapy, you can make the tumor vaccines. So DC, the dendritic cell vaccine, have produced delay in the disease progression and even the regression of established osteosarcoma in animal model. Oncolytic virus can be used for They are attenuated virus genetically engineered to only replicate in malignant cells. And this one is called a telemogene or a TVAT, was found to produce a response in a patient with a melanoma. It is FDA approved. And another thing is the most important, which is coming in a big way, that is a CAR T cell therapy that target HER2 in OS other than what we have a CD19 or CD22 CAR T cells for acute leukemias. So these are a few trials going on. One few are phase 1, phase 2 trials related to the antibody therapy targeting cell surface protein. These are a few more trials for adoptive cell therapy, dendritic cell therapy, and vaccines. More than a 50 or more than a 70 trials are going on under NCA with various names and with different targets. And these are few list of the anti-PD-1 and PD-L1 monoclonal antibodies. This nivolumab is, we know that pembrolizumab adult uses quite oftenly. So these are a few names. And what is the targeted therapy? So I will tell you about a few lines about the targeted therapy. It is started for the breast cancer HER2 with the trastuzumab, which targeted the HER2, and the latest what I mentioned is the 2021. Though the later on there are a lot of targeted therapies are in the market. So we have many targeted therapy nowadays. Now, how they work? So we know in the normal without molecular targeted therapy, what are the how the proliferation, growth, survival, angiogenesis, metastasis occur in a normal cancer cells. Then there's the growth factor cytokines. They actually promote or they activate the various pathways, and the growth and proliferation take care. So either you can block this growth factor or receptors by the small molecule targeted therapy like tyrosine kinase, like therapeutic monoclonal antibodies, or you can specifically target that pathway. So, for example, tyrosine kinase inhibitors or serine threonine kinase inhibitors. Other same way, the MAP can be used to bring more NK cells to the cancer cells or more neutrophils to the cancer cell and cause the death of the cells. This is the general term. This I have taken because we should know the pathway by which particular tumor has grown, like osteosarcoma. This is example for osteosarcoma, where PDGFR, IGFR, VEGFR are activated. There are the RAS and PI3K pathways involved, which include the protein synthesis, cell migration, cell survival, and the gene expression, cell proliferation. And there is a cell cycle inhibitors are there, like V1 and then ORKAB, which can actually inhibit the cell cycle. Particularly, they have the role in osteosarcomas. So these are signaling pathway and gene responsible for that. One example I can give, PI3K or mTOR, that is the main genes which regulate the signaling pathway: EGFR, GNQ, L, PDGFR, PDGFR beta, CBL, PI3K, CA. So there are the different pathway and different targets are there. So you should know where you should target. For example, DNA damage repair pathway, that can be actually and its implication like V inhibitors, inhibition of CDK4 by palbociclib. So there are the different target for different pathways. So like these are the all example. The very common example is the sorafenib, which is the PDGFR, VEGFR inhibitors, and have some role in osteosarcoma or various sarcomas or various tumors. So these are a little bit about the introductory part of how the immunotherapy or targeted therapy works. And this is, I'm going to present two cases which has been actually diagnosed as the infantile fibrosarcoma. And this is the paper which focuses into how much dose at what length of the therapy you should use your medications. So this is the first case, a 6-month-old boy presented in month of February 2023. His swelling in the right forearm. Parents noticed the swelling from last 1 month, which was gradually increasing. Detailed workup was done, including local site MRI, biopsy, then fusion gene study. The final diagnosis was infantile fibrosarcoma. It was an inoperable disease. So I started on RMS-like therapy with vincristine, actinomycin, cyclo. But after 8 weeks of that, MRI showed a mild increase in the size of the lesion. So anyhow, we contacted to the buyer's company and they were ready to supply the larotrectinib. And you see, this is the microscopic. So the diagnosis is confirmed infantile fibrosarcoma. It has a fusion study when we done, then it turned out to be the TPM3 and TRK. So we know that NTRK can be targeted, and there is a now good case reports as well as the phase 2 studies where the larotrectinib is used in cases of infantile fibrosarcoma. So you can can see the clinical picture as well as the MRI finding. The huge mass around 8.1 to 4.25 centimeters there, and engulfing the ulna as well as going up to the radius. And then when we gave after 3 months, this was the below picture. You can see this is the clinical picture as well as the MRI. It's difficult to find out. Only the plaque-like thickness is there in a MRI. The second child is actually neglected when she was diagnosed at the age of 1 year. Huge mass, the parents neglected, though the diagnosis at the same time was infantile fibrosarcoma. She came to us at the 6th year of age. We have the same medications, so it is inoperable at the beginning, but later on when we give this, because we have that drug, but we cannot give to this child, so we find out the in-between way, and we gave the few doses of the this larotrectinib to this child. So the tumor cell express NTRK and immunonegative for CD1, CD30. We confirm the diagnosis. It is infantile fibrosarcoma, and this ETV6 and TRK fusion gene were positive. These was post 1 month, because we want to take her as early as possible for the surgery, because we don't have a much supply of that drug. So there is significant reduction to that size. So then we did a MRI, and you can see the MRI shows a good response. Now she's planned for the, she has actually planned, but unfortunately she underwent for a this R2 rejection. So we have written the company, they are ready to give us a more chemotherapy, more larotrectinib. With this, I think this is about the little bit basics about the immunotherapy and targeting therapy. Now I would like to invite Dr. Prashant. Dr. Prashant is here.
Yes, I'm here. Yeah.
Okay, so Dr. Prashant, can you start on your this thing? Presentation?
Yes.
Yeah, please.
Thank you, Pankaj, and team for inviting me to give a talk on targeted immunotherapy for refractory and relapsed B-cell ALL. Am I audible?
Yes, sir. Yes, you're audible.
Yeah. Okay. So a very simple talk. Thank you for setting up the scene, Pankaj. Very good cases, interesting cases. So here I say the race is on. There is a reason why I say race is on, and I'll touch about it at the end of the talk. I have no disclosures. So we all know that B-cell ALL, I mean, very high curative rate. We are able to cure up to 80 to 85% of children just with chemotherapy, although it's a long drawn course of chemotherapy. However, if they were to have a refractory or a relapse disease, and especially early relapse, then the survival curves are as low as 30%. So you can see here, this is a landmark study from Dr. Vaskar et al.'s group, and they show that the outcomes are as low as 30%, the event-free survival. So clearly, we need newer therapies for refractory and relapsed B-cell ALL. So why are we not able to cure these patients with refractory and relapsed B-cell ALL? Because with just transplant, we are not able to cure them. Because if they go into transplant with MRD positive disease, then the majority of them relapse. And that's the reason transplantation in this patient does not work without getting them MRD negative. So the key is getting them MRD negative before putting them through transplant. So that's our main hurdle. And that's why many of these patients eventually don't end up getting transplantation, because we are not able to get them MRD negative. So has this changed now in the era of targeted immunotherapy? So we had this 16-year-old boy who came to us somewhere in, I think, 2021. He had pancytopenia with high blast cells in the peripheral blood, and the flow cytometry showed B-cell ALL. He was not PH or PH-like. He was treated elsewhere initially with BFM90 induction, and post-induction his MRD was 18.42%. So in the previous era where immunotherapy was not available, I mean, we didn't know how best to treat this patient. We just kept on giving one after another chemotherapy. But this patient is clearly chemotherapy refractory. So it will be very, very, very unlikely that we'll get him to get his MRD to such a low level that he would then be transplantable without high risk of relapse. So these patients in the past, majority of them, we were not able to cure them. And there is another patient with relapsed B-cell ALL, a 3-year-old boy with B-cell ALL treated with BFM95 elsewhere. His post-induction MRD, he was negative, so good response there. However, he unfortunately relapsed at M2, and he relapsed with CNS disease. And at that time, he had bone marrow blast of 45.4%. So again, this was the early relapse. How do we treat these patients who have had such early relapse? Of course, previously we used to give them mitoxantrone-based treatment or FLA-based treatment and see if they responded. And if they responded, then we used to transplant them. But however, a large number of patients, we were not able to get them into, we were not able to get their MRD to such a low level that they would then be easily transplantable. So has this changed now? Okay. So what has happened in the last few years? So you can see allogenic SCT, it clearly is a form of immunotherapy, but it doesn't work if the MRD levels are high. So in 2014, we had blinatumomab, and then in 2017, we had inotuzumab. And of course, in the adult setting, rituximab was also shown to improve outcomes in adult ALLs. And then in 2017, the first CAR T-cell was approved by US FDA, that is Kimbria. And then there are a number of different CAR T-cells that have been approved since then. There are up to about 6 approved by US FDA. And then we have our own CAR T-cell of Immunoact that has recently been approved for relapsed and refractory ALL for patients above 15 years of age. So it's becoming a very crowded space, and how to rationalize these treatments and how to rationalize these treatments in India is the key for all of us. So therefore, I'm only going to put an Indian perspective or Indian spin on it. I'm not going to talk about the international perspective. So we have many options. Okay, so just a bit about blinatumomab. Blinatumomab, also a BiTE technology. What it does is it tells your immune system to kill the leukemic cell. So it binds both to the T cell and the CD19 antigen, which is on top of the leukemic cell, and it allows crosstalk between the two, so that the T cells become activated and then kills the leukemic cell that expresses CD19. Okay. Now, several studies have showed excellent efficacy of blinatumomab, especially with low burden disease. However, patients who got high burden disease, that is MRD of more than 5%, 10%, they don't respond that well to blinatumomab. And they are also at increased risk of cytokine release syndrome. As you can see in this bar graph shown below, so there were less treatment emergent adverse event in patients who had low burden disease compared to in patients who had high burden disease. So it's very clear that blinatumomab does not work very well in high burden disease, and it also increases the risk of cytokine release syndrome. So we clearly do not want to use it in high burden disease. We want to keep it restricted to the low burden disease. That is what blina is telling us. At the same time, inotuzumab, which is another technology, which is an antibody that is tagged to a cytotoxic agent, calcimicin, and it tells it kills the cells expressing TD22 with the help of this cytotoxic agent. Okay, so again, it's a fantastic technology. It's been there around for quite some time now, and the first well-known antibody in hematological malignancies was gemtuzumab in AML. Again, we are still trying to optimize how to use that antibody best. But let's stick to inotuzumab. So inotuzumab, again, is a very good drug. It works well. The difference between inotuzumab and blinatumomab is that inotuzumab works well with high burden disease. So no matter what the burden of disease is, if you give inotuzumab, the response rates are as high as 80%. As you can see here, this is a pediatric study of about 25 patients where you're seeing the initial response rate, like 1 to 3 months, is quite high, as 80%. So in this study, 18 out of 25 patients became MRD negative. So again, a fantastic molecule. The question is how best can we use both these molecules? Can we use them together? Can we use them separately? Can we use them with chemotherapy? So all of these questions are asked internationally. And basically, the questions are not being answered, to my mind, in a very rational way, because there are other options like CAR T cells in the international world. So to optimize the use of these novel therapies, we designed a sort of Wadia hospital protocol, which uses blina only in low burden disease. That is, if your MRD is less than or equal to 5% with CD19 positive disease, then we use blina only. And if your MRD is higher than 5%, then we use inotuzumab followed by blinatumomab, if the disease, of course, is CD22 positive and CD19 positive. And we looked at this, the patients who have received these therapies in a retrospective way to study what their efficacy and toxicity profile in this patient is. So these patients were treated from May 2021 to January 2023. These patients are specifically treated in the 2 units in the country. One is Wadia Hospital, another one is MVR Cancer Center, Kochikode. So we defined end of induction minimal residual disease more than 5%, or end of consolidation minimal residual disease more than 0.1% as refractory. So this was the definition of chemorefractory disease. And the definition of relapse disease, whether it's high risk relapse or intermediate risk relapse, was based on the COG North American definition. So patients who had end of induction MRD of more than 5% and were more than 16 years old, or had high risk cytogenetics, or had end of consolidation MRD of more than 0.1%, were treated on this protocol. And patients who had end of consolidation MRD of more than 0.1% were treated on this protocol, irrespective of the age or cytogenetics. And the other group of patients, that is the relapse group of patients, if they were high risk or intermediate risk relapse patient, they were treated on this protocol, especially if their post-relapse induction MRD was more than 0.1%. And second relapse with any level of residual disease after the induction were treated on the protocol. So blina was given as a 28-day continuous intravenous infusion, and inotuzumab was given, and now we know the standard way of using inotuzumab is a fractionated dose, and that standard dose was given. All patients were consented for immunotherapy, and we got permission from hospital core committee to do the retrospective analysis. Standard definitions of overall survival and event-free survival were used. And we also compared the overall and event-free survival in patients who had relapsed disease before we started the immunotherapy protocol versus after we started the immunotherapy protocol. So far, 19 patients have been treated across many of these patients have come from different states to us. The median age is 12 years, 2 to 17 years, and 2/3 of these patients were more than 10 years of age. 5 were girls and 14 were boys. Cytogenetics was high risk in 7 patients, so 3 had low hypodiploidy, and 1 each had one of the other high-risk mutations like IAMP21, MLL rearranged ABL1, IKZF1 deletion. 5 patients had extramedullary disease, 3 were CNS, and 2 had testicular disease. 8 patients out of 19 were chemorefractory. They were all external referrals. 4 had induction failure and 4 had consolidation failure. 11 patients had relapsed leukemia. 6 were early relapse. 2 were late relapse, and 3 were second relapse. The 2 late relapses had high MRD post-relapse induction. So these patients, the 11 patients that had relapsed leukemia, 11 out of 5 had received 2 previous chemotherapy lines. Other 5 had received 3 previous chemotherapy lines, and 1 patient received only 1 chemotherapy line. So what was their disease burden? So you can see patients who had blinatumomab only, their disease burden was somewhere between, this is shown on a log scale, somewhere between 0.01 to less than 5%. And patient who received inotuzumab followed by blinatumomab had disease burden ranging from 5.5% to 72%. So these are the outcomes, and this is a swimmer plot of all our patients that have been treated and had subsequently received HSCT. So I am a bit colorblind. So the HSCT is this color. So majority of patients have undergone HSCT after receiving immunotherapy. And in the entire group of 19 patients, we have had 1 non-responder that didn't respond to inotuzumab. We had 2 TRMs, this one and this one. The 2 TRMs were to one patient died of capillary leak syndrome post-transplant, and another patient died of adenoviremia post-transplant, and we had 1 relapse in this group. So this is to show the survival curve. So out of the 19 patients, approximately, out of the 19 patients, 15 are surviving, so giving us a survival outcomes of event-free survival of up to about 80%. And when we compare relapsed leukemia patients only, so 11 patients versus the patient that have had relapsed leukemia before we started this protocol, you can see majority of patients pre-immunotherapy did not make it long-term, whereas post-immunotherapy, up to about 75 to 80% of patients are event-free. So as I said, we compared this with a previous group of patients. So in the patients who received disease burden adapted immunotherapy protocol, there was 1 non-responder, so that patient clearly went for palliation. 18 patients achieved MRD negativity, of which 16 underwent transplant. Of those 16 patients, 13 are in CR to date, 2 were transplant-related mortality, and 1 was relapse. 1 patient received autologous stem cell transplantation because of high-risk factors like parvovirus, adenoviremia, and the abnormal liver because of hepatitis C. And 1 patient chose to go maintenance chemotherapy, again, because of high-risk factors such as parvovirus and adenovirus. But that patient till day stays in CR. However, before starting this protocol, we had 20 patients. All patients were relapsed leukemia patients. And when we look at them, 7 opted palliation because, of course, the outcomes are not good in this group of patients, therefore they opted palliation. 13 patients were treated in UKLR3, of which 5 became MRD negative, and of those 5, 4 were TRMs and 1 received HCT, and that HCT is in CR to date. And there are others who either were MRD positive or were treatment-related mortality to chemotherapy or non-responders. So what is the safety of this protocol? So 9 patients developed mild CRS, 7 had grade 1, 2 had grade 2. 2 patients had grade 1 neurotoxicity that recovered just after transient discontinuation of blina. 1 patient treated with inotuzumab had grade 1 CRS. 6 patients who received inotuzumab followed by blinatumomab have undergone HCT to date. And of the 6 patients, only 1 patient had mild VOD. No patient had grade 3 or grade 4 side effects of immunotherapy. So again, going back to the case that I present first, that was a patient with chemotherapy refractory BALL. The patient went on hyper-CVAD in the transplant center they were in the center that they were been treating. and post-CVAD MRD was low. So we consolidated with Blincyto, and the patient received TBI-based mud transplant and is disease-free at 903 days post-HCT. The second patient that we discussed had relapsed B-cell ALL with high disease burden, was given inotuzumab, became MRD negative, and then was consolidated with Blincyto and had undergone TBI-based mud transplant and is disease-free at day 90. So, I mean, we can't not talk about CAR T cell if we are discussing immunotherapy for BALL. So in India, what CAR T cells do we have? So there are two early phase trials, ImmunoACT and Immunil are the companies doing this trial. ImmunoACT CAR, we know, is approved for 15 plus years of patients on the basis of safety and early efficacy. Although approved, it is too early to say whether this will translate into long-term efficacy, and I'll explain to you why. So in adult patients, 15 years plus patients, phase 1 and phase 2 combined trial was presented in American Society of Hematology meeting 2023. Leukemia patients are very early on in treatment, so it's hard to comment whether this is going to translate into long-term efficacy for leukemia patients. Lymphoma patient, there is good long-term follow-up, but if you look at first 12 lymphoma patients who received CAR T cells with residual lymphoma on board, only 1 out of 12 are in remission to date. So again, we don't know whether this will translate into long-term efficacy or not. So in terms of CAR T cell and in terms of Indian CAR T cells, we need to have long-term data to explain to our patients whether how many percentage of patients will continue to have long-term remission, etc. So it's too early for us to jump into starting treating our patients with CAR T cell without having long-term efficacy data. I think this needs a bit more of standardization so that we understand how these CAR T cells, whether this CAR T cell translate into long-term efficacy or not. With that, I conclude my talk. I think our protocol of using sequential Blina or Blina alone based on disease burden has proven efficacious, and we continue to see this efficacy in our patients who continue to receive this treatment. So the study data cutoff for the study was October 2023, but since then we have treated more patients and we continue to see same efficacy. This protocol potentially can transform the care of refractory and relapsed leukemia patients globally. In terms of CAR T cells, standardization and cost is likely to be prohibitive for development of CAR T cells in India. To date, we don't know how Bharat Serum ATG works. The reason why we don't know the exact efficacy of Bharat Serum ATG is because it was never optimized. And that's why Bharat Serum ATG, we cannot put hand on our heart and explain to the patient that X number of patients with aplastic anemia will benefit with Bharat Serum ATG. I hope same does not happen to the CAR T cells from India. So it's very important to standardize CAR T cells at the time of phase 1, phase 2, phase 3 trials, rather than approving it and marketing it before we understand the long-term efficacy of these treatments. So with that, I conclude my talk. Thank you very much, Pankaj and team, for inviting me. Some of these slides were prepared by my colleague, Dr. Sana. So thanks to her as well.
Yeah, thank you, Dr. Prashant, for such a wonderful insight about the Blina, CAR T, and Natuzumab. So the thing is, definitely the listeners or our audience benefited with the your experience as well as the principle of using this thing. So we have a few questions later on at the end of the presentation of Dr. Badira. We will discuss few questions. So here I think Dr. Badira is there. So can you present your presentation? Hi, Dr. Badira.
Hi, Pankaj.
Yeah, so you can start. So Badira is going to speak on a immunotherapy or targeted therapy in a pediatric solid tumor. So she will give an insight. I think we will finish it with time limits. Thank you.
Yeah, I think that is my cue to just run through it or gallop. Okay, thanks Pankaj, and thanks Monica, and thanks the Cancer Kids for having giving this opportunity. So I think you have all had a very good overview from Pankaj, and also the context in the setting of pediatric hematolymphoid malignancies. So I'll try to, in the next few minutes, give you an overview how we stand in the setting of pediatric non-CNS solid tumors with respect to targeted therapy and immunological agents. So the scope of the talk, we'll just have an view of the molecular aberrations that are most important to us with respect to this therapy, and the targeted agents available, the impact, utility, and the challenges which are faced. And also we'll have a peek into the immunotherapy options which are available for the solid tumors in this era. So if you look at the targetable molecular aberrations in non-CNS pediatric solid tumors, I have arranged some of the druggable, actionable targets which we see in solid tumors, non-CNS tumors. And left to right, I've put it in that order because they are seen in according to the cancers which are most commonly encountered in the pediatric oncology practice. So ALK aberrations, as you have all know about, is an in thing with respect to solid tumors, especially in the setting of neuroblastoma. The aberrations can be fusions, but unlike the hematolymphoid, where fusions are the most common, fusions are not the most common in pediatric solid tumors, except in the setting of IMFT, which is a non-rhabdomyomatous soft tissue sarcoma. Most likely, we see ALK amplification and ALK single nucleotide variants or the point mutations in the setting of neuroblastoma, with trials currently running for the same. Then we have this group of NTERK aberrations, which all of you had a glimpse with Pankaj's two cases. And where we stand, with respect to the NTERK aberrations and treatment, we'll come in a few slides. And others are ROS, PDGFR, MAPK pathways, BRAF mutations, and the PI3K mTOR pathway inhibitors, which are used in such lesions. And these are not a majority, but yeah, some of these GIST tumors, fibromatosis, IMFTs, all have these mutations, and we'll not touch upon a lot of these. We'll go into the main targetable mutations and the options available. So I think NTERK fusion is something, whenever you think of targeted therapy in the setting of pediatric solid tumors, that is non-CNS, NTERK is something that pops up into our mind because the NTERK inhibitors are around and available and approved for use in pediatric age. Now, the overall incidence, if you look as of NTERK fusion positive tumors in pediatrics, which includes both hematolymphoid and solid, is 0.34% to 2.2% across various studies. Now, if you look at it compared to the adults, this is actually higher. In adults, you see around 0.33%. So this is the overall incidence across all tumors. But in pediatrics, if you look at it, specific cancers are enriched with NTERK fusions. Now, especially the prototype of which is infantile fibrosarcoma. More than 90% of infantile fibrosarcoma has NTERK fusions. And the other tumors are the cellular congenital mesoblastic nephroma, which also has more than 90% NTERK fusions. Now, thyroid cancers are being recognized as having 1/4 of them having NTERK fusions, and also CNS tumors, especially the infantile hemispheric gliomas. They're both low-grade and some of the high-grade gliomas are also known to be enriched with NTERK fusions. Now, if you look at the several phase 2 trials in pediatric age group with respect to the NTERK inhibitors, The objective response rate, which includes complete and partial response, has been to the tune of 90 to 100% in children with NTERK fusion. But mind you, something that has to be kept in mind, all the NTERK negative tumors had less than 5%. So currently, with respect to inhibitors, these are to be used only in the context of fusion positivity. But what is pleasurable and so it's happy to note, as Pankaj rightly pointed out, the rapid remissions and the durable remissions which are seen with respect to the treatment in such tumors. Now, if you go to the clinical implications, now NTERK is taken, this NTERK fusion is taken as a very genomic focused, a compilation of a tumor histology agnostic and age agnostic group of tumors. We have the NTERK rearranged sarcomas, which can be across different grades, low, intermediate, and high grade. This is because the inhibitors are have action and have potency across all these grade of tumors. Now, where do we use this with respect to pediatric solid tumors in this setting? Now, it's of use as rightly shown in demonstrated in Pankaj's case also. In upfront setting, where do you use? In a setting where you have a locally aggressive tumor, especially infantile fibrosarcoma, you know, is a very locally aggressive tumor where surgical morbidity can be expected, where you cannot attain an R0 resection and that could amount to an amputation, especially in a child that can be devastating. You don't want to go there. So in such cases, there is an indication for NTERK inhibitors in the NTERK positive tumors. And if in cases where you attain a CR, maybe even surgery can be eliminated. So this is a case of infantile, 2 cases of infantile sarcoma. You can see such big tumors in such small children and very locally aggressive, and the tumor surgery would have been morbid and amounting to amputation, disfigurement, and would not have been possible also in the first case. So this is a setting where you can consider targeted therapy. The other setting is in the metastatic setting or the unresectable tumors. So here also there is a role for targeted NTERK inhibitors, especially in the setting of infantile fibrosarcoma or NTERK fusion, any NTERK fusion positive tumors. Also, as I've said, some of the CNS tumors also have NTERK fusion positivity, and especially where penetration and things can be difficult, and high-grade gliomas where the otherwise the prognosis is low. The presence of this offers target which can be dealt with the NTERK inhibitors, and there has been good outcomes in this setting. So the challenges with respect, we have NTERK inhibitors available, first, second, third generation NTERK inhibitors, which are available, some of which are available in India, some of which has to be imported. Now, what are the challenges with respect to its widespread use in the current setting or in the setting as we know it? One is its definite role in the current clinical scenarios are not robustly or very solidly proven. It's better defined in infantile fibrosarc, as I've said, especially in refractory cases, recurrent setting, and also in the unresectable setting upfront. The role of NTERK inhibitors is quite defined. But how long and all is still to be defined better. And in respect to CNS tumors and other neoplasms which are NTERK fusion enriched, we don't know where we stand with respect to their role in treatment. And also how to use this best with chemotherapy so that you can come down the development of resistance. And also we don't know what is the role of adjuvant NTERK inhibitors in post-surgical resection in fusion-positive tumors, such as if you're giving, you're doing upfront surgery in a case of infantile fibrosarcoma, whether with margin positivity, without gross residual, how do you deal with the adjuvant NTERK inhibitors? So these all needs better definition. Duration of therapy, as I've said, we don't know the definition of an endpoint. We don't have a definition of an endpoint, though in studies it is continued in trials till progression. That's the endpoint of those studies. Otherwise, most of these targeted therapies are given for minimum 1.5 to 2 years. But even though we don't have a thorough definition, maybe with newer studies, maybe cell-free DNAs and all those things, we can have a better definition of an endpoint. There is the development of resistance, especially when they are used as monotherapy. The monitoring of resistance is also important. Treatment strategy in such cases, this resistance is mainly due to kinase domain mutations. They can also be due to alternate pathway activation. So switching over to an mTOR inhibitor, multi-kinase inhibitor, or other pathway inhibitors based on the resistance, which will require further testing and confirmation, would be the way to go. And also difficulty in administering, especially in the pediatrics, because many of these tablets, they cannot be scored, crushed, or chewed. There is a liquid formulation for an mTOR inhibitor, larotrectinib, which has to be again imported. It's expensive, yes, in the current setting. So we need to correctly select a population whom the benefit and the cost-benefit ratio is going to be the best. Hence, this is a challenge in the current context. Okay, and long-term adverse effect, as we all know, the TERK is important in neural development again. So these trials are all led to approval in 2018-19, and hence the long-term adverse effects on the neurodevelopment is yet to be seen and explored, and hence we need more studies with respect to that. Now, how do we do molecular testing? I'm not going into the details of this because we have a panel coming. You have an IHC, but IHCs always require confirmation with the sequencing, or even a FISH would do if it's affordable. And if you have a neoplasm in which you know that the driver mutation is going to be entered, like a fibrosarc, maybe if NGS is not, a FISH can be used also for treatment decisions in such a case, but mostly IHCs will require further confirmation. So this is a good flow diagram, which I got from a Singaporean task force recommendations on whom to test for mTOR in pediatric sarcomas. I'm not going into the details. So it is said that wherever you suspect, or in pediatric cancers which are undifferentiated, where you do not have a relapsed refractory setting or a metastatic setting, where definite driver mutations or genomics are not known, like neuroblastoma, Wilms, or hepatoblastoma, with the exception of these, you can do a sequencing wherever affordable, if not a FISH. And if you got a positivity, you can go ahead with mTOR inhibitors as a second line for sure. First line, if standard treatment is not available. And if only IHC is positive, go ahead with sequencing and confirm with it. But otherwise, if it's negative and NGS is negative, there is no role for mTOR inhibitors. Now, this is the second group of alterations which are currently in news, and that is ALK alterations in neuroblastoma. It can be in the form of amplification. Usually in the upfront treatment naive setting, it's usually to the tune of less than 5% cases, which can be detected by an IHC, FISH, or an MLPA. Now, ALK point mutations are the most common ALK aberrations in neuroblastoma. These are seen in 10 to 12% of the sporadic cases, mostly missense single nucleotide variant. And there are several point mutations to note. These usually constitute around 85% of the point mutations that we know now. Now, the problem with ALK point mutations is most of these are whatever I have described now. These are activating point mutations which can be targeted with inhibitors and would work. But some of these point mutations which have hitherto not been mapped could be inactivating. So in that set, an inhibitor would not work. And these two are mutually exclusive, and many times ALK amplification is associated with NMIC, and they usually give to a more aggressive form of the disease. Now, in relapse disease, there is an increase of 4 to 7% ALK alterations, because with relapse or refractory, you can see more ALK up to the tune of up to 25%. Now, ALK inhibitors in neuroblastoma, what are the problems? Single agent is usually associated with resistance, so they're combined with chemotherapy. You have the first, second, third generation in that order. Now, what are the challenges with respect to ALK aberrations in neuroblastoma? Now, prognosis and therapeutic effect clinically, but not yet conclusively proven. Now, some of these mutations, which is the F11 cellulose, inherently resistant to first and second generation. So the third generation, lorlatinib, is being studied and investigated, and is supposed to be effective in this mutation. Now, if you look at the two mutations, the first paper is from MSKCC, in which they looked at the differential impact retrospectively of ALK mutation with respect to survival, and they didn't find any difference with respect to survival. But the second study, this is a Cyopen study, they did show that the ALK mutations and amplifications are independent prognostic predictors in high-risk neuroblastoma. So we yet need a conclusive proof of the same with respect to ALK mutations. There are different types, as I've said, so yet to be fully mapped. There is a problem of resistance. This first mutation is inherently resistant, so you have to go over with third generation ALK inhibitors. Now, their integration into the current standard of care still needs better definition. Now, COG has a study which the results of which are yet to be published. There are technical difficulties, as we have already pointed out with the rest previous one. They cannot be scored, crushed, or chewed. The duration of therapy, again, we don't have a definite protocol with respect to that, especially with respect to ALK point mutations. So this is another IMFT is an RSTS, which has 50% of which has ALK positivity. It's a very locally aggressive tumor. It can be, and there is a high risk of local recurrence if you don't get an R0. Where there is surgically resectable, we can go ahead with surgery. Other options are available in the form of what has been listed. So 50%, as I show, ALK positivity. So inhibitors can be given, especially in unresectable, progressive, or refractory setting. Even in negative tumors, in an IMFT context, there can be some activity in ALK inhibitors, mainly due to ROS fusions. This is especially the effect is seen with respect to entrectinib, which also inhibits, irrespective of ALK, ROS also. Now, fibromatosis is another something that, as pediatric oncologists, you don't want to have a patient because it's not such a malignant disease. But then again, attaining a CR and cure from fibromatosis is quite rare, and it's a recurrent thing. And the patient also will be recurring to you, and you don't know what to do with this. So usually, surgery, because of infiltrative in nature, it's difficult to get an R0. There are various treatment options available. Now, imatinib had been tried, but the response rates are less and long-term side effects are more with respect to that. Now, sorafenib is something which has shown to be effective as a TKI in advanced and refractory desmoid tumors and had a very good 2-year PFS to the tune of around 75% with respect to sorafenib in relapse and refractory desmoid tumors. And the dose, even though specified is high, 1 at 50 mg per meter squared BD in the trial. In this, it's an Indian study, mainly in adults, where it showed that sorafenib dose can be come down, and in the Indian setting, we can come down to a lower dose. This is we have also seen in our practice where sorafenib has been given in a lower dose, and it still did show response. The problem with sorafenib is it cannot be crushed, scored, or chewed. Now, I'll also give you, and that is with respect to the targeted therapy, the main druggable, actionable mutations and the inhibitors in the context of pediatric non-CNS solid tumors. Now, with respect to the immunotherapy, I'm sure all of you are aware of anti-GD2, so I'm not going into very much details of it, but I'll just go through the main points. The main targets are GD2 and the immune checkpoints. It's best defined currently in neuroblastoma, where in the upfront setting in high-risk neuroblastoma, it has caused one of the highest jumps in survival with respect to overall as well as EFS. And also these are defined in MMRD-associated pediatric cancers, mainly in the setting of constitutional mismatch repair deficiency. You have different types, dinutuximab and beta, depending upon the source and their chimeric. We have naxitamab, which is also approved, which is humanized. Naxitamab, the problem with dinutuximab and dinutuximab beta both requires admission, inpatient admission, long hours of infusion. There is capillary leak syndrome and all those toxicity. Naxitamab can be done on an OPD basis. It's half an hour infusion, and the toxicity profile is less. So in the setting of anti-GD2, currently where we stand is in upfront disease, high-risk neuroblastoma pose a standard of care therapy. So it is currently standard of care in upfront disease. And also in relapsed refractory disease, if you use it in combination with chemotherapy, high response rate has been to the tune of 53% has been obtained with respect to by using anti-GD2 immunotherapy. Now, immune checkpoints, because their low mutation burden, pediatric cancers and downregulation of MHC1 expression, infiltrating T cells are less, and hence immune checkpoint inhibitors has not worked as good as or I can say that it has not worked at all with response rate less than 5% in pediatric solid tumors. As you can see, the current evidence is only in the setting of MMRD and DNA polymerase deficiency, especially brain tumors or any tumors. I mean, it's not just brain tumors. Any brain tumors in this setting, there is evidence from immunotherapy, I mean, immune checkpoint inhibitors. And also there is amazing evidence in SMARC deficient tumors like rhabdoid or ATRT. Now, CAR-T in pediatric solid tumors, we have the anti-GD2 CAR-T for relapsed refractory high-risk neuroblastoma. The phase 1-2 trial showed that there was good response rate. About 1/3 had complete response, and another 1/3 had partial response, and which was sustained. And with multiple GD CAR-T infusion, there was sustained response in patients, even at median follow-up of 1.7 years. So this is something which is to be looked into, and we don't know where it stands with respect to the integration into the current clinical practice. So we are seeing a shift from one size fits all to a more personalized cancer treatment with precision medicine, but there are problems with respect to the technicalities of this diagnosis. And also, if you have a targetable mutation, the drug availability is the limitation. Now, even if you have drug availability, the affordability is a limitation, and the administration. And also because of this, there is no definite protocol with respect to a lot of tumors, how to use it, when to use it, how long to use it. So I think it's finding the right, the perfect fit of lock and key, and put it spot on. That putting it spot on, right, requires, as I said, all these things, the challenges that we have already discussed, to be better defined, and where we stand with respect to that depends a lot on the availability, affordability, and also better defined protocols in the case of pediatric solid tumors. Yeah, thank you.
Thank you, Dr. Badira, for such an insightful presentation. Now we know, we have an idea about what is going on, what we can do, and how important to understand the complexity of the immune system in a solid tumor as well. So with this, I think we can start on our panel discussion. Next 15 or 20 minutes, we will finish this session. So I would like to start with the Dr. Prashant, though he has actually explained the difference between Blina, inotuzumab, CAR-T cell. Still, I would like to ask him how to choose between Blina, inotuzumab, and CAR-T cells. Dr. Prashant.
Yeah, so I don't think currently we have any choice, because in pediatric CAR-T cell, to my knowledge, is not approved in India yet. It's still in trial phase. So currently it's not an issue, but if you're talking, let's say the CAR-T cell was available, the key to know is what is the long-term efficacy of any treatment. Until we have that data, I mean, we can't put it over and above the usual treatment. So our usual treatment is chemo-based treatment. Now we know with chemo-based treatment, the outcomes of relapsed refractory leukemia, if we don't get them into good CR with MRD negativity, the likelihood of relapse is high. So therefore, to get them into MRD negative status, we have options of Blina and inotuzumab now. Both are available in India. I think inotuzumab is available. Blina, I think we still have to import it. We have access to Blina through St. Jude's program. So thank you to the St. Jude's program. So how to choose between Blina and inotuzumab is the question. So we discussed Blina for low burden disease. If somebody got low burden MRD, then we can say give Blina and then do a transplant. But if somebody's got high burden disease, then one should consider inotuzumab, get them into low MRD negative, and then use Blina. The other method of getting high burden disease, making high burden disease to low burden disease is using a chemotherapy. So if somebody was forced to use a chemotherapy instead of inotuzumab because of lack of funding, affordability, then the way I would choose chemotherapy in these patients is what have these patients not been exposed to before. So for example, if they were not exposed to fludarabine, if they're not exposed to mitoxantrone, then use those drugs rather than the drugs that they have been already exposed to. So if they have been exposed to methotrexate, no point in again giving them methotrexate to reduce the disease burden. So that's one principle I would follow. The second thing one can do is I think venetoclax is a new drug, and I think it's also a very promising drug. So one could consider using venetoclax also in the setting to reduce the disease burden if access to inotuzumab was an issue. And then the third thing about when to use CAR T cell. So right now we don't have access to it, but if we had access to it and if it was approved, CAR T cell with the current knowledge of long-term efficacy, which we don't have, one would reserve that for patients who cannot tolerate transplant. One would reserve that for patient who received a lot of chemotherapy, does not have good performance status. I think those are the patients that one would reserve it for. Once we know that the long-term efficacy of these CAR T cells is somewhere between 40 to 50%, then maybe they could come above or they could come equivalent to blina, inotuzumab, and transplant. So that's where CAR T cells stand at the moment.
Yeah, so thank you for such a insightful this thing. Now, though we have in Indian scenario, we have inotuzumab available with us. So Blina is not in our reach until unless somebody actually have a money. So though we naturally we have actually choice of the drugs, still it will help us to actually take a decision. So the next question is I would like to ask Badira, what factors should be considered before advising immunotherapy and or target therapy in solid tumor in children, except the cost? You know that cost is issue, but other than what factor you take into consideration?
Okay, I mean, if you're telling first 2-3 years cost, the rest would be now. So I think it is important to choose your population rather than going for a broad indication where to use. So first would be the setting of I think first I would choose those tumors which are known to have such druggable or actionable targets. So you can choose your tumor type. Then maybe in the refractory relapse setting or in the metastatic setting, unresectable setting, if you have, then those are the ones whom you can choose for sequencing and find out if there is any druggable targets. And because many of the pediatric tumors, undifferentiated tumors, so those might have a lot of targets, and maybe exclude those tumors like Wilms having some, or which are known to have other drivers or known not to have these druggable targets, because it's not just about doing a sequencing. Now, the thing is about, again, drug availability. I mean, do you have the drug? And then, of course, yes, first and foremost, are they affordable for the drug? And then you have to use those things. So I think it's about choosing your target wisely in the current context.
Right. So yes, so this is very important for us in Indian scenario where cost is also issue, but the thing is that once we know what actually the pathway is involved, then that is a better way to understand the disease as well as choosing your immunotherapy or a target therapy. So there are a lot of students who joined us. So I would like to ask Dr. Om Shri that what are the germline mutation and what are the somatic mutation? We have a few questions regarding with this. So if Madam can answer about or can brief us about the germline mutation and somatic mutation. Madam, can you switch on your mic?
Sorry. Germline mutations are the mutations which could be passed on from your egg or the sperm, or to say that from the germ cells. So like, and these are being passed on from the parents to the offsprings, and it would be like, if the mutation is present, it would be present in any cell of the body. Whereas somatic mutation is the mutation which would affect in an individual's lifetime, and this usually happen in sporadic tumors and where the germ cells are not involved. So, and these mutations cannot be transmitted. So, and these are only into the specific tumor cells in the body. You're muted, Dr. Pankaj.
Yeah, so it is very important to us to know. They also actually we have a few questions regarding that. But it is important, for example, in GMML, whether you are dealing with the germline mutation, whether you are dealing with the somatic mutation, or even how they behave with their methylating property. So you can even your chemotherapy will change depending on their methylation. So this is there. And the next question is actually. I think we can go for the next question. So what are the challenges in creating a tumor-based NGS panel? So Dr. Suruchi is with us. If, she can answer this very important question because the next few questions are related with these questions. So what are the challenges creating the tumor-based NGS panel? Dr. Suruchi?
Sure. Thank you, Dr. Pankaj. Just before going on to this question, like the previous question, what we discussed about germline and somatic, I just wanted to add one point there. So like you mentioned in JMML patient, the mutation can be germline or somatic. So it is very important when we do a next generation sequencing on such patients and we do get a somatic report because we'll do a panel or we'll do the test on the blood. Blood will have normal as well as mutated cells, transformed cells. So the report that we will get may have a somatic or a germline mutation. So it is very important to distinguish whether it is a somatic mutation or a germline mutation and understand whether there is any germline predisposition. So followed by that, the test confirmation on the buccal swab is required for that particular mutation to ascertain whether it is germline mutation or not. So that helps in further understanding whether the mutation is germline or a somatic. So coming on to the question to me, so basically when a NGS panel is designed, basically there are multiple steps. First of all, we have to define our objective. What are we going to test? So our targets needs to be defined. So we have to curate a gene content or a target regions in the genomes. After that, we have to basically look at the sample type, on which sample type we are going to detect the mutations. And we have to select the sequencing platform. We have to define the bioinformatics pipeline. And once the design is ready, as per like what target regions are there in the genome, we have to validate the panel. We have to get on some reference standards or some clinical sample validation to understand how the panel is behaving, what is the sequence metrics, what is the quality of the data, what is the sequencing at which depth at which we have to use it, what is the coverage we are getting. So there are multiple bioinformatics parameters that we have to look during the validation, and reproducibility and repeatability of the results. So we basically define the sensitivity and specificity of the assay during the panel validation. And once it is validated, we have to get it accredited, and then only we can use it for clinical analysis. Tumor-based panels, as specifically being asked, is difficult. Why? Because tissue is an issue. So DNA is usually fragmented. So we have to define the bioinformatics characteristics very particularly during the panel validation, how it is behaving, because there is a lot of data loss when we do the sequencing on FFP tissue due to various reasons.
So actually, for a clinician purpose, it is very important. For example, if I want only the mutation or a driver mutation or a pathway to look into osteosarcoma or a rhabdomyosarcoma, I don't want to waste money on the whole panel of the sarcomas, So
Right, sir.
then we ask for the particular, if you have this comprehensive panel for this particular disease, for example, we have for leukemias, at least comprehensive panel for the leukemia. So that is our clinical questions or a clinical worries about the money.
Exactly. Yeah, this is the major question that I get, but I just want to clarify because we have a lot of people here. When we design a next generation sequencing panel, if it is like about 20-25 genes, whether it is a single gene or a 20 gene panel, the cost will not change. And I mean, it's like, we may think that why to go for a comprehensive panel if we can go for a single gene, like for example, BRCA1, BRCA2 versus a hereditary comprehensive panel for hereditary cancer predisposing genes. Some people will prefer only BRCA1, BRCA2, or some people will prefer a 25 gene panel or a 100 gene panel. So 25 gene panel and BRCA1, BRCA2 gene panel, the cost and the backend process doesn't differ. It's just when we design a panel, it has to be designed for at least 385 reactions. So as a lab, we have to look into that, like how many samples we are going to get it, because probe itself will be cost intensive. So that's how we design the panel, and therefore it doesn't matter much when we, offer like that. That's the reason, Foundation One and other, they have just single tests available in the portfolio. But because we have a lot of varieties here as per, demand.
Yeah. So it's nice to actually hear your problems. I can understand we have our own problems, which is very important to share or know your problems so that we can
And
ask
as
what is
I,
available.
yeah, exactly. And as I mentioned, every panel we design has to undergo intensive validation, which is time intensive and a cost intensive process as well.
Yeah.
Otherwise, we cannot offer it for clinical diagnostic purpose.
Right. So we also have Mukta madam with us. If she can hear, I know she underwent today's root canal treatment, so I'm not sure whether she is able to answer. But if she is here, if she can answer role of molecular studies in diagnosis of sarcomas or difficult to diagnose the sarcomas.
Yeah, Pankaj, yeah. So I think I can manage some talking.
Yeah.
Okay, so your question is, when we are diagnosing a sarcoma, when do we ask for molecular studies, right?
Yes, ma'am. Yes, ma'am.
All right, okay. So let me just tell the audience, which I'm sure are not very many of pathologists are there in the audience, but it is an algorithm. We always start with the clinical information, radiologic inputs, biochemical inputs wherever they are required, and with that context, we look at our histology. And that histology, I must tell you that in around 90% of cases, or maybe even more than that, with the help of immunohistochemistry, we should be able to diagnose a particular sarcoma. Now, I'm talking about pediatric sarcomas more than the adult sarcomas, because specific diagnosis is attained with these modalities till immunohistochemistry in more than 90% of pediatric sarcomas. This rate can be lower in adult type of sarcomas. But pediatric, yes, they are more amenable to specific diagnosis, which is extremely important for treatment planning. And it is achievable. Now, there remains a certain percentage of tumors, which in spite of extensive immunohistochemistry, extensive brainstorming, and the morphologic analysis, they remain undiagnosed. And in that case, we will have to resort to something more. And then what is that something more? As of now, it is molecular testing. But then what do you do? Like, do you subject the entire tumor to the next generation sequencing? Okay, so answer is, if you have money, if you have the resources, please go ahead and subject that tumor to an NGS. But then there comes something even before NGS, and those are our routine FISH testing, where we detect the fusions. Mostly pediatric tumors have different kind of fusions by which we diagnose the sarcomas very specifically. So go ahead with fusions. In cases of some neuroblastomas, go ahead with amplifications. But now today's topic is more than that. We are talking about the next generation sequencing and what is their role specifically in diagnosis. And we heard a lot about, targetable genes panel earlier by the earlier speakers. Here, the issue is slightly different. We are not looking at the targetable gene here, but we are using NGS for the diagnosis. So let me just try to tell you, and maybe Dr. Omshri might chip in as well again here, that the panel that is designed for the diagnosis of sarcomas is different than the panel that is designed for targetable genes. Okay, so the panel for the diagnostic genes are different. Okay, you might have different genes wherein they are not really used for the targets. That is something as specific. So we might subject those tumors for diagnosis. And very common examples where we face as pathologists, where we face the diagnostic difficulties are round cell tumors and some spindle cell sarcomas. Now, when it comes to round cell tumors, more and more round cell tumors are now being defined with specific gene signatures. Like, just take, for example, Ewing sarcoma. there was an era where we only knew about EWS Fly1. That was the definition of Ewing sarcoma when it came to molecular signature. But now within the family of Ewing sarcoma per se, there are more than about 10 to 15 gene fusions that exist. And on top of it, now we also know that there are certain round cell tumors which we earlier considered as Ewing sarcomas are not really Ewing sarcomas when we talk about their molecular signatures, but they are completely different. Like, for example, the sick ducts rearranged sarcomas, or the the BCOR rearranged sarcomas. Earlier, everything was under the umbrella of Ewing sarcomas, but now they are more and more specifically being defined. In fact, the rate of the discovery of the mutations that exist in these tumors is far more outpacing the clinical knowledge and the clinical relevance of that discovery. We still do not know what that fusion or whatever that mutation means, or how do we treat it, what is the prognosis of that treatment. And one very classic example, as Dr. Badira just elucidated to, is the NTRK mutations. Okay, there are different NTRK mutations. There are certain tumors which are clinically more evolved for years together, like in infantile fibrosarcoma, and we are applying this knowledge of NTRK rearrangement to these sarcomas, and we are using that for as a treatment modality. We are getting the results. But then there are certain sarcomas which do have the NTRKs, but we don't really know their morphologic spectrum. We do not know really how they would behave in a manner when they are targeted with a certain drug used for anti-TRK. So you can subject these sarcomas to the NGS panels. They might come up with some mutations, but we have to be very, very judicious about utility of that knowledge in the clinical setting. As to, it was already said that we don't know whether to use a certain drug or no, if that entity is not clinically very well defined.
Right. So yes. So, madam, yeah. So this is actually very important for us as well to know when, because most of the time we are associated with that, we see the clinical or targets which we can hit. But now there is another aspect that yes, NGS or other molecular way to diagnose or to reach some difficult cases of the sarcomas. So definitely it will help us. And if I can.
Yeah, I mean, what I want to say is that, we are spending money on the NGS, and we are literally churning the genome and churning it in the hope of obtaining something targetable. It doesn't really mean that it will eventually lead to clinical response if that particular entity is difficult to diagnose in first place and not better defined in a clinical or histologic sense.
Yeah. So that one is important aspect. I think the screen is not shared, I think.
It is shared. Just right click and put next, no, Pankaj?
We can see.
It can. Yes. So then to Dr. Prashant, we have discussed a lot of things actually. So, but important part is there. Is there a role of prophylactic cranial RT or cranial boost with TBI for conditioning in the era of targeted therapies?
Yeah, so more and more centers are moving away from cranial radiotherapy because of the side effects it comes with. So I think there is a big one-liner to say that there is no role of prophylactic cranial RT or cranial boost with TBI in the current era. And maybe there may be a complex patient where it may be useful, but that should be discussed with the tertiary centers, and then a decision should be taken. Otherwise, there is no role of giving prophylactic cranial RT. We see a lot of patients who come to us after having received loads of cranial RT, and then we have to put them to transplant. It just makes it very difficult to then transplant them in a sensible way. So therefore, I would say in the current era of where we got so many targeted therapies now, we should try and not give cranial radiotherapy.
All right, so that will save a lot of toxicity as well in a growing brain. So the thing is that the other thing is for the Badira, this question, as a common finding, there is no comprehensive panel for various pediatric solid tumor. So how you order your molecular test? So that I think one important part is whether it is targetable or not targetable. Other thing is can focus on that or can elaborate.
I think, Pankaj, I think this has been quite nicely answered by Dr. Mukta. Also have given a overview of where to go ahead and when to order and what it would yield. So as we have already discussed, we have to take it in the context of what you're dealing with, what type of tumor.
Right. So the very important question for us this is for Dr. Om Shri. What are the indication of doing a germline mutation in pediatric malignancy? Should I ask every pediatric patients to go with that, or it is like for few patients only I should ask for that?
It depends upon a lot of factors. I mean, basically, with the family history, the kind of disease it is, the etiology, and the most suitable approach would be the tumor first testing. So once you do the tumor first approach, you would be able to pick up most of the germline mutations. And in case if you come across those, then there is any point in going ahead with the germline testing. I mean, rather than straight away going ahead with germline, of course, you need it for several conditions like some sarcomas or in retinoblastomas. And if there is a family history and if the father or mother or one of them would have had it, then there is a merit. But then again, there is a it need to be traded with caution. Like, there are a lot of, the things like when to put the child into testing or at what age it need to be tested or how much to be tested. So all these need to be weighed and with a lot of pros and cons. So all in all, if you look into the literature also, for majority of the pediatric malignancies, the tumor first approach would be the better one to go for.
Yeah. So I will share one quick scenario. We had one patient who diagnosed as a Burkitt's lymphoma in 2020, and he was treated well. And then in 2023, last year, he came up with the mediastinal mass, turned out to be T lymphoblastic lymphoma. And then we searched up for this particular patient. We have done the germline because it is a it is not a relapse. It is another malignancy. So we did, and it turned out to be the Lynch syndrome. So. Then we did parents as well. So mother is also having the same, though the penetration is less. So mother is not affected anyway, but this child is having it as a T lymphoblastic lymphoma.
Exactly, because the
Pankaj, at this moment, I'll just chip in with just one thing.
Yeah.
Like this is a very vast subject about germline mutations, what diseases, what tumors. But when we are dealing with the clinical scenario, I think the CMMRD is the most tricky of the disease, which has germline mutations and varied clinical presentations. So that is one thing that we need to always keep in mind. So any child who is very, very young, presenting with high-grade CNS tumors, high-grade hematolymphoid malignancies, I think they should be subjected to germline mutations for the MMR genes. Yeah. And they are autosomal recessive. So, the disease manifestation is always very, very early in life.
Yeah, so Pankaj, if I may chip in one line about that, I would like to say that even though the germline mutation spectrum in pediatrics is not well defined and it's not well established, even though we have studies from the Western, our Indian scenario within the Indian population, the distribution of it and what to do with, if you see a pathogenic germline, how does it with respect to the particular mutation, whether, because some of these are well known, CMMRD, it's well known. Now, Elifromany, TP53 is well known. Now, what do you do with BRCA? I mean, in an early onset leukemia. I mean, or some other cancers, PAX5. I mean, we don't know what it stands. I think it's very important to have that mapping in the spectrum also in the Indian population. And currently, what we do in our hospital also is we do it based upon triad of the tumor, physical characteristics, and the patient characteristics, not just family history, but a lot of other patients. So that's a selective targeted candidate, testing. And we have a high incidence of with that also in a pilot population, up to 30% incidence but we have a referral bias because we have such patients. Yeah.
Right. So that is actually very well answered and supported by all the three speakers actually. So it's a very good to make us some concept whether we should go for a germline mutation or not. So Madam Suruchi, Dr. Suruchi is there with us. So if she can elaborate the concept of what is the whole genome sequencing, what is the exome sequencing, what is the clinical exome sequencing. So Dr.
Sure,
Suruchi,
sir.
can you in a brief
Sir, I would like to share my screen if I can.
Yes.
Is it visible?
Yes, it is visible.
Okay. So I just want to share this slide. Just a second. I'm trying to put it in.
Yes.
Yeah. So basically, the question is like, what is the difference between clinical exome sequencing, whole exome sequencing, and whole genome sequencing? So as the slide shows, right? So the genome is organized into genes and intronic regions or non-coding regions. So genes are further categorized into exons and introns, right? So the colored part shows the exons, and the other parts are intervening sequences are introns. So when we capture a certain particular genes, right, a particular set of genes, that is called as targeted panel. And in clinical exome, what we do is we have a set of characterized genes for which we know what disorder is mapped, and they are well characterized clinically. So those genes, when we are targeting only the exonic region, it is called as clinical exome. So exonic region, I mean the complete exons of that particular gene, plus there is a padding of around 10 base pair inside the intron. Those splice regions are covered, so which will cover the splice variants as well. So that is called as targeted panel, or if we are doing the clinical exome, we call it as clinical exome panel. Whole exome panel, irrespective of the characterization of gene, there are about 20,000 genes in human genome. So all exonic regions of all of those 20,000 genes, including the splice regions, if we target that is called as whole exome sequencing. In whole exome sequencing, there is a new term which is called as we call it as ExomeMax. Basically, it is a proprietary panel, the experienced whole exome sequencing, we call it as, because when we use commercial whole exome panels, there are certain regions which may be uncovered due to sequencing bias, or due to further, there are some technological reasons why some regions will not be covered properly, and some regions will have good diagnostic yield. So to cover those regions, proprietary panels are designed so that though all the regions are uniformly covered, and we can improve the diagnostic yield of whole exome sequencing. So those panels are called as ExomeMax or Exome Plus. So they improve the diagnostic yield over the commercial panels. So ideally in these panels, the exonic regions of all 20,000 genes are covered. And when we say whole genome sequencing means exons as well as introns and other non-coding regions, promoter, regulatory regions, everything is covered. And here we don't do any capture. Here complete whole genome sequencing is done. So what are the advantages and disadvantages of these sequencing is that clinical exome sequencing or targeted panel sequencing, what we do in most of solid tumor cases, or liquid tumor cases, or basically somatic testing, we use in clinical diagnostics, we use targeted panel approach, because we can categorize or we can target a particular disease. We can sequence up to thousands of genes starting from either 1, 2, or even a hotspot panel. And we can achieve high coverage and depth for those set of genes. For example, if I want to just cover lung cancer actionable targets, I can design a panel of about say 12 to 18 genes, and with high coverage and depth. So my diagnostic yield will be higher because I'm only targeting that particular region, and the cost will be low because the data amount that we have to generate through sequencing will be low. And accuracy, obviously, because the depth of sequencing will be high, so accuracy will be higher with smaller panels. When it goes to whole exome sequencing, it still have good accuracy because we are still targeting only the exonic regions. But when we go to whole genome sequencing, since the amount of data that we have to generate is quite high, the cost becomes high, and the coverage across the regions is lower, and therefore we get lower accuracy. But whole genome sequencing has an advantage that we can even cover all structural variants, which when we do targeted panel sequencing or whole exome sequencing, the coverage for structural variants, large deletions, duplications may not be there because the breakpoints can be intronic or in non-coding regions.
Yeah, so very well actually taken. This will help us whenever we order the actually whether we want a clinical or we want the whole genome or we want a whole exome sequencing.
Yes. So basically for solid or for tumors, to identify actionable targets or to identify treatment, we go from 1 to 500 gene panel, mostly 500 gene plus 500 gene panel is most comprehensive panels that we have. And otherwise the panel can start from certain hotspots, just hotspots only. So usually targeted panels are used for cancer. However, for germline mutations, it depends. It can be clinical exome when the diagnosis is very clear. If there are differential diagnoses or there is overlapping diagnosis, we are not able to make out what syndrome it is, then clinicians might go for whole exome sequencing, or we nowadays we are giving exome max for better diagnostic yield. And whole genome sequencing is used when we want to, basically in research settings, or when we want to look at bigger picture, including structural variants as well. Nowadays, we do offer a combination of whole exome sequencing and a whole genome sequencing so as to cover everything. It's like complete understanding of the genome.
Yes. Very true, very true. So, Dr. Suruchi, thank you for this thing, this wonderful slide. And then we come to our questions actually. This is about the again with the ALL therapy. So what are the role of other targeted therapies in acute lymphoblastic leukemia? So Dr. Prashant can tell us about
Yeah, so one very important thing, I think by now everybody is aware of this, but when we have a relapse or refractory leukemia, the first thing to make sure is whether they are Philadelphia-like or not, because that's an important targeted therapy. So that's something to bear in mind. I mean, I feel we should be doing it upfront in all the patients, but maybe all the centers cannot do it. But it's very important to know whether the leukemia is Philadelphia-like or not, because then that changes how we treat them significantly. Other than that, in relapse and leukemia setting, we discussed the role of venetoclax is obviously there. It's not fully explored. One of the questions I can see is that somebody has asked about a combination of azacitidine and venetoclax. I think the combination of azacitidine and venetoclax is considered in a relapsed or refractory AML setting. I don't know the role of azacitidine in ALL, but venetoclax certainly can be used in both ALL and AML.
Yeah. So we are actually a little bit sort of time. So one or two questions. So there is a role of a molecular target like PDGFR, VGFR, sorafenib in metastatic setting, like for example in osteosarcoma. So for example, when we do in a relapse refractory setting or in a metastatic setting, where we know that our outcome is not very good. So is there any role, or because we know they have some role, we add them? So Dr. Badira, can you highlight this?
Yeah. So if you're talking about osteosarcoma in specific, I mean, I can say, whatever.
Like general, or you can take it as an example.
Yeah. So even if I take it to osteosarcoma specific, even in them the trials, whatever has shown is like a very the median PFS and whatever benefit is like 3-4 months or whatever, and the response rates are very poor. I mean, you have got 1 or 2 PRs and mostly progression. So I don't think in the current context in the pediatric setting there is no robust evidence to provide any recommendation and for consideration of these therapies, even in the setting of refractory or relapsed osteosarcoma. I have to say that off record, I mean, we also have tried in a few, but it didn't work. It all progressed with this sorafenib and this thing. So currently we don't have, and I don't think it's to be recommended or done outside of a clinical trial.
Yeah, so only NCCN regorafenib is where in OGS setting relapse refractory, they say as you can use a regorafenib as I think as a first line for the relapse refractory osteosarcoma, and that's the NCCN guidelines for the adults.
Yeah, not for pediatrics.
So, right. So that is there, and so this is for Dr. Omishiri. Now we are at the end of our discussion. So what is the role of a liquid biopsy in single cell omics in pediatric neoplasm? We heard a lot about the liquid biopsy, but can you highlight a little bit about in pediatric neoplasm?
So yes, it plays a very important role in terms of MRD, and there are different types of it, like DNA-based alterations, RNA-based fusions if one need to detect. So then liquid biopsy definitely plays an important role, where you cannot obtain all the time biopsies, and you need to do a continuous monitoring, or for that this is needed. And depending upon the type of alteration that one need to detect, the assays would vary. Like it can start from something like flow cytometry. You can use droplet digital PCR, or one can use real-time PCR-based assays, whether it is a DNA-based or RNA-based. So even more comprehensive can be, liquid biopsy-based NGS assays. So everything has its own pros and cons. Like, some assays might be more sensitive, the assays sensitivity, and especially when it comes to detecting the minimal residual disease. So you need assay which need to be extremely sensitive. So it's as good as like finding the needle in the haystack, but still one need to depend on that kind of a test. Whereas NGS, you'll be able to detect all kind of alterations if biopsy is not available. But in case of leukemias, when you want to look for MRD, when you know that there is one specific alteration and you're looking for that only, then you can resort to single gene based testing. Someone was asking like whether one can use Sanger or NGS in the discussion. So Sanger, of course, one cannot use. It has its limitations to tissue based. Like here you're looking for something really minute amount, like almost like one mutation or one alteration. So in that time, you need to choose like what platform one need to use, what is the expertise available, what's the infrastructure, and what's the costing. So, and yes, liquid biopsy is like become the biggest thing now, like more than the tissue based biopsy.
Yeah. So I think this last question for Dr. Mukta ma'am. So can you comment on the correlation or predictive pattern of the morphology with the molecular subtyping?
Again, it is a very general question, but I might answer this with one or two examples. I think when it comes to correlation with morphology and molecular correlation, rhabdomyosarcoma stands out as a very dominant group, wherein we can distinguish between embryonal rhabdomyosarcoma and alveolar rhabdomyosarcoma on morphology. Having said that, it is not 100% sure. So we can certainly say that this is most likely to be alveolar rhabdomyosarcoma, and we need to go ahead and do the molecular testing for FOXO, like PAX3 and PAX7. Both of them. And our policy at Tata Hospital at the moment is that we subject all rhabdomyosarcomas to molecular testing. It is like blanket testing, but the histologic correlation is pretty strong to the extent of, I must say, around 85% or so. But then in our own experience, about 12% of our categorically diagnosed embryonal rhabdomyosarcomas have shown fusion. And again, some rhabdomyosarcomas who did show alveolar pattern did not turn out to be fusion positive. So, but even then, morphology is a very strong predictor of the fusion status. Another tumor I might say is a neuroblastoma, wherein if a neuroblastoma is undifferentiated, if it has high MKI, then it is a strong indication that it might be showing amplification. So in pediatric age group, I think these are the two tumors which morphologically are indicative of their molecular correlates. And then now some new entities are emerging, like the PANTR and the NTREC rearranged sarcomas. They do have their specific morphology, the sick ducts rearranged sarcomas, even Beaker rearranged sarcomas. So when we look at the morphology, we can say that this is not a typical Ewing sarcoma. This might turn out to be a Beaker rearranged sarcomas.
Right, madam, right. So I think I should say thanks to all my speaker, my panelists to actually make this session very meaningful to our audience. And if some comments or questions are there, we can actually directly pass on to the speakers and panelists. So thank you, everyone. And I actually invite Dr. Monica if you want to say anything. So thank you, Dr. Prashant, Dr. Mukta madam, Dr. Omishri, Badira, and Dr. Suruji.
Thank you, everyone. Dr. Pankaj, it was a good webinar. And thank you, everyone, for joining in. Dr. Prashant, Dr. Badira, Dr. Mukta, Omshiri, and Dr. Suruji. I really thank you all for this nice discussion. I have no comments. The only thing is I want a photograph with Dr. Pankaj. So if everybody can switch on their cameras, that is all I want.
If you had told this earlier, we would have dressed up more.
I actually sent a message in the group, but that's okay.
Okay.
Dr. Prashant, just let us, Dr. Pankaj, just let us know when you've taken your shot. Otherwise, we'll keep on smiling.
Okay. I guess you have.
Thank you, everyone.
Thank you. Thank you, everybody.
Thank you. Bye.
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 Good night. Bye.
Bye. Bye.
Thank you so much, everyone. Thank you so much. Good night.